name is Franka. I work at CDC, and for today's presentation, I would like to give you a few basic information about rabies virus pathogenesis. So louder. Okay. So good morning. Can you hear me? Okay, also. Today in my presentation, I would like to give you some basic information about rabies virus pathogenesis, and specifically as it relates to laboratory diagnostic and decision-making process for post-exposure prophylaxis administration. Objectives would be describe pathogenesis and its relationship to decision-making process regarding human and animal rabies control and prevention. I will be talking briefly about current knowledge regarding Rabies virus pathogenesis, phylogenesis, and also I will discuss in more details individual variables which are involved in rabies virus and Lissa virus pathogenesis. As most of you know, rabies is acute progressive viral encephalitis caused by Lissa viruses. Annually, more than 60,000 people die from rabies worldwide. Rabies is one of the oldest diseases, and but despite the fact that there is no treatment, it could be easily prevented. There are multiple strategies. One of the most important, oral vaccination of wildlife, as well as parenteral vaccination of domestic animals. One important part is also avoiding any rabid or suspected rabid animals and avoiding exposures. And if those happens, there is vaccination. All warm-blooded mammals are susceptible to rabies. There are many reservoirs: bats, raccoons, wolves, cats, foxes, mongooses, etc. Rabies virus could be transmitted mostly through bite and virus-containing saliva of an infected host after injury, when it is injected essentially into the muscle, or when virus or saliva are in contact with mucous membranes. And there are obviously rare cases of organ transplantations. There is no viremia in rabies, so virus cannot be transmitted through blood. Here, just to give you some graphic information about diversity of rabies virus reservoirs and hosts. As you can see, there are many different reservoirs at different continents. The diversity of the reservoirs is reflected also in diversity of rabies virus variants and the genotypes which are circulating worldwide. Currently, there are 11 genotypes or 11 Lissa viruses we recognize from classical rabies virus, Lagos band, Mokola, Gulenhage, European band Lissa viruses. 4 novel Lissa viruses, Aravan, Pujan, Irkut, and West Caucasian, which were discovered just recently in the last decade. And there are 2 more which are not yet recognized taxonomically as new genotypes. It is Shimoni virus and Kokelek virus. And if you attended the RITA conference, there were presentations suggesting that new Lissa virus was discovered, so there may be more than 14 currently. Majority of Lissa virus genotypes, they are divided to 2 phylogroups, phylogroup 1 and phylogroup 2, based on the essentially based on the genetic properties and also ability to be neutralized by conventional vaccines which are prepared for genotype 1 virus. Despite the fact that there is diversity between different genotypes and also there are many different variants, rabies virus has essentially they all have similar structure consisting of 5 proteins: nucleoprotein, phosphoprotein, matrix protein, glycoprotein, and L protein, with G protein being mostly responsible or related to pathogenesis and pathogenic properties of viruses in great extent, but obviously other proteins are also involved in pathogenesis. So after the brief introduction, now I would like to discuss or present some basic information about pathogenesis and virus spread. Once a virus enters tissue after a bite, it spreads through sensory or motor neurons towards the CNS, where replication takes place, and after replication in CNS, virus is being slowly transported through nerves to peripheral tissues, including salivary glands, skin, and many different organs. There are no differences in spread in different mammals. There may be differences in incubation periods and susceptibility, but the general mechanism of spread through neurons is similar for any mammal. So as I mentioned before, after replication in CNS, virus is being spread through neurons to many different organs. Obviously, we learn most about rabies virus pathogenesis, the virus spread through animal models of testing. And here is just one example where we were studying rabies virus spread in a hamster model. So just to give you a few information about, the main question was how virus is spreading, what's the kinetic of virus spread, when we can expect virus to reach spinal cord and CNS. Obviously this is not impossible to study in humans, because after infection, incubation period could last from weeks to months, even sometimes years, and once virus enters the nervous tissue, there are no changes. Only a few days before, essentially, humans start to showing signs. That's when you can start, if you test samples, that's when you can start realize where virus was. So we use animal models to help us understand virus spread. In this particular case, after infection, administration of virus to gluteal muscle, we were doing serial euthanasia and trying to detect virus at different parts of spreading. As you can see, after 4 days, virus could be detected already in the lumbar part of spinal cord, and after 6 days, we were able to detect virus in the brain. So essentially, in this particular case, with this particular virus and dose, virus entered CNS after 6 days. It is important, however, to mention that even though we were able to detect virus in the CNS after 6 days, hamsters in the group were still apparently healthy. So it means virus was already in the brain, but it takes few days, at least in this particular model, for animals to start to show signs. So virus could be detected in CNS, and in most cases, this virus is already spreading to peripheral tissue, to salivary glands and other organs, even skin, but animal is still apparently healthy. And that's the major reason if you come into different situational cases why animals are spreading virus few days before they get sick, and similar is true for humans. So even apparently healthy people, few days before they show symptoms of rabies, they may have virus in saliva. And main reason is that the virus is already replicating in CNS. There are no apparent changes in behavior until virus replication reaches a certain extent in the brain, but virus is already spreading. Obviously, this was just one particular virus, one particular dose in this one particular animal model. If we use different dose of virus, if we use different route, if we infected, let's say, masseter muscle, if we use higher concentration of virus, all those numbers and spread data would be completely different. So this needs to be taken into account that it is biology, it's not mathematics. If there are differences in input, you cannot expect same results. On this graph, I would like to discuss maybe or transfer information we gain from animal models, but also information we gain from years of studying the different human rabies cases and epidemiological data, and we put it in a simple graph. So on this graph, you may see essentially from the start, from the beginning, that after infection, virus gets into the tissue, into the muscles, and either replicates or enters nerves and spreads towards CNS, as I discussed before. However, there is one important thing I need to mention now: the rabies virus, especially pathogenic variant, evolved to be able to avoid immune system responses. So essentially, even data about replication on the site are not clear. If replication occurs, it's not in a large extent. There are few publications suggesting that virus replicates in the site in some animal models. There are other data where there is no replication observed. So even if it happens or not, essentially it cannot be detected until virus gets to CNS and spread peripherally. So in a case of infection, virus enter tissues, cannot be detected during incubation period, which could be a few days, up to a year or even 2 years. Obviously 90% of human rabies cases incubation period is within 6 months, and there are rare occasions when incubation could be longer. Based on current knowledge, it's not truly understood or known what is happening with virus during this long time of incubation period. If the virus is spreading with in this slow mode to CNS, or if it's somewhere else, that's not clear at this moment, since it is based on animal models. It is known that once it reaches CNS and starts to replicate, it takes only a few days before animals or humans develop symptoms and signs of rabies. And as you may know, once symptoms of rabies start in humans, rabies is almost 100% fatal. After the incubation period, when virus reaches CNS, usually, as I mentioned before, rabies is acute encephalitis. So it means within few days of short prolonged period, there is acute neurologic period, and within 2 to 3 weeks, majority of patients died. As you can see on the graph, virus first reaches CNS and after spreads to salivary glands, and this is the way when it could be transferred to other hosts or reservoirs. This is true mainly for animals. In humans, humans shed virus in saliva a few days before they show symptoms of rabies. They shed it in saliva during the disease. However, shedding is intermittent. So in many cases, if you collect samples every day, someday you can detect virus, next day it may not be there. So that's important to mention. Besides, I mentioned before, rabies is almost 100% fatal, but it could be prevented. And at this graph, you may see in the black lines are depicting situation when there is no post-exposure prophylaxis, when a patient either doesn't seek medical attention or he doesn't receive any vaccine or immunoglobulin. If a patient goes to see a physician, and obviously there was exposure, they suggest post-exposure prophylaxis, which on this graph could be depicted by blue line, which is passive immunization, administration of immunoglobulin, and red line, which is active immunization, essentially response of host on patient's immune system to vaccination. So as you can see, main reason for administering passive immunity or human immunoglobulin is to neutralize virus on the site of infection. Those antibodies are already prepared, so it's passive immunization, and their biological half-life is anywhere between 2 weeks and 3 weeks. So in 2-3 weeks, those immunoglobulins won't be there anymore. One of the major reasons why in recommendations, which will be discussed later today, is that immunoglobulin has to be administered as much as you can around the wound, is exactly for this reason that these antibodies could neutralize virus in the site of infection. So as soon as you administer it, and as much as you can around the wound, the better for the patient. However, at the same time, there is administration of vaccine on day 0, 3, 7, and 14, according to current recommendations, which will be discussed later. And main reason is to build immune response in the patient during the time when passive immunity is being. So after immunization, red line is essentially response when patients start to produce their antibodies, and those also participate in clearing virus from periphery. Essentially, rabies in human cases should be always included in differential diagnosis in any cases with neurological symptoms of encephalitis or myelitis. Patient's history is really important to give us idea if there was any exposure or if there was travel to countries where rabies is present for the patient. However, it's not the only clue. In many cases, we do not have history. If patient came to a facility or hospitals and they are already they have fever, they have encephalitis. In many cases, they are in either induced coma or coma as a result of encephalitis, so we cannot get those information. In those situations, besides clinical presentation, laboratory diagnosis is essential to distinguish if this is human rabies case or not. And Lillian Orsiari will be talking later about advantages and disadvantages, different methods for detection. There are few indications of possible human rabies case and also some negative indication. As I mentioned before, from positive, those are different neurological signs, increased white blood cells count in CSF, and fever, obviously, and acute progress of the diseases. In some cases, negative indicators are if patient status is improving or it remains static. It most probably is not rabies. Usually, majority of rabies cases or patients, if they are not treated, the morbidity period is between 2 or 3 weeks. However, this is not a rule. Sometimes, especially these days when the physician, especially in developed countries, are trying to use Milwaukee protocol or its modification, using different antivirals, even though they are not specific for rabies virus because they are none. Using different medical intervention, this could be prolonged between few weeks, 6, 7, 8 weeks, etc. So even though it's negative indicator, we usually don't use it as a caveat. Here on this slide, this is mostly for there are definitions what is being considered a human rabies case, and definitions are essentially evolving as diagnostic techniques are improving, and you can gain much more information from the patients. But basically, it has to be case with clinical representation, and there has to be either detection of rabies virus antigen or nucleic acids, or presence of antibodies, either neutralizing or binding antibodies in serum and CSF. And obviously, it is good if every case has to be laboratory confirmed. And there are multiple laboratory methods which could be used for Ante-Mortem diagnosis. And as I mentioned before, Lillian, next speaker, she will discuss it in more details. So conclusions: rabies virus spreads via nerves initially unnoticed by immune system. So it may take weeks or years, and there is no sign, or there is no diagnostic method which could tell you if somebody was infected. Sometimes we have people calling CDC and saying, for example, oh, I was bitten 7 days ago by this animal, it cannot be found. Can you do a test to find out if I have rabies or not? There is no test we can do because virus could not be detected. There is no immune response to virus, since virus is avoiding recognition by immune system, and essentially it could take weeks or months, and there is no immune response, there are no antibodies, there is no virus being detected in any tissue. So essentially this is important part, especially for diagnosis, that you cannot detect it only after a few days before they start to show symptoms of rabies, and that's when we start to do ante-mortem diagnosis. Virus reaches brain before any signs or symptoms occur. As I discussed before, when patient starts to have fever and all the typical symptoms of rabies, malaise, confusion, paresthesia, going into paralysis and confusions, there are...
Mr. Blanco, can you turn up the volume a little bit, because basically I can barely hear you.
Okay.
Thank you. Appreciate it.
No problem.
Sorry for interrupting you.
Yeah, sorry. If you didn't hear, yeah, this is almost end, but but good at least for conclusions. Yeah, so rabies virus reaches brain before any signs or symptoms occur. So that's important to know that essentially it's already when we receive samples from the patients, when they start to show fever, paresthesia, and other symptoms of rabies. That's already stage when virus is being replicated and in extent in a brain. So essentially those signs are result of virus replication in neurons and their modification of their function. So at that point, obviously we do ante-mortem diagnosis, and Lillian will discuss samples we need for testing. But virus is already in the brain and was in the brain based on different animal model studies, maybe a week or two before. So when patients arrive to the hospital, they have been sick for a few days, and virus could have been shed in the saliva. So as a result, there is always epi investigation for the contact and possible exposure, and usually it's with 2 weeks prior to the start of the symptoms and signs, because essentially virus was being shed in saliva prior. As I mentioned, there are 4 major samples absolutely necessary for ante-mortem diagnosis, and the reasons are essentially, as I mentioned before in the graph, that there is no immune response. Once we detect immune response in a serum or CSF, this is possible only when patient is sick. Depending on the stage we receive samples, if it's at the beginning of morbidity period, usually there is a lot of virus present in peripheral tissue, so we can detect virus in the skin and possibly in the saliva. But as diseases progress, there is increase in antibody production during morbidity period. Virus neutralizing antibody are usually increasing in serum and CSF, and they are able to neutralize virus also in periphery. So as we progress, for example, if you had a patient who was sick just for 3 days, most probably we can detect virus either in skin or saliva, but likely there are low titers of antibodies in serum and CSF. As diseases progress, within 3-4 weeks, there are titers rising in serum and CSF because of immune response from the patient. But at the same time, these neutralizing antibodies are neutralizing virus, mostly in periphery. So if we test only some peripheral tissue like skin, there is no virus detected, and sometimes not even in saliva, because it's being neutralized by antibodies. And in those cases, we can detect antibodies in serum and CSF. This last point is that distribution of the virus in the brain could be different in humans as well as in animals. So essentially, in some cases, there is possibility to do brain biopsy in the patient, even though it's not used frequently because they are in critical state, and brain biopsy could even more, increase the risk of different reactions. But even small brain biopsy could allow us to detect virus in the brain. But since it could be distributed in different parts, negative results may not rule out presence completely. Thank you. I will be happy to take your questions now.
We'll be happy to take questions from the floor. Also, Mr. Peter Acosta from World Rabies Day will be leading the discussion through the webinar.
Yes.
Yeah, I've read through the years in the MNOUR all these exposures by nurses and doctors once they have a rabies case, and I was just wondering how infectious is the saliva, and does the saliva have to have the same criteria as an animal bite, that it has to have contact with mucous membranes or that it's penetrating? How infectious is the saliva of a patient?
Yes, thank you. So question was, if you couldn't hear it, how infectious is saliva from human patient during the time when the patient is shedding virus in saliva? So essentially, criteria are same as for exposure with animal. Either there has to be bite from the patient to nurses, or there has to be penetration of the skin, either with needles or any other instruments or tools, or patient saliva could come in contact with the eyes or mucous membranes. And most of those exposures happens, sometimes they are incidental needle stick, but generally if nurses and physicians are following regular practices, for any infectious disease, they are using gloves and they are not bitten or scratched. If they use, when they are changing, for example, if patients are intubated and they are changing tubes, if they have face shields, so in those cases there is no exposure. They are not exposed.
What do you do? What do you do when somebody says, I'm not sure? Those gray zones, do you usually vaccinate?
Essentially, each case, if there is case identification, there is questionnaire and epi investigation. So either State Health Department or EIS officers from CDC, they help to sort this out. So people are being asked multiple questions, and essentially that's being evaluated. And usually through this process of discussion, they may have some questions, but at the end they decide if there was exposure or not. And in most cases, they will not need post-exposure prophylaxis. Your other part of your question, how infectious it is. As I mentioned, shedding is intermittent. So, if there is no virus, it's not infectious. But if there is virus and it gets into the tissue or mucous membranes, infection could start. The question is just what kind of virus it is. Different variants may have different pathogenicity. What's the route? If it's bite, it's more dangerous than just saliva on intact skin. In those cases, it won't be exposure. Essentially, there is, I think, only one, and Dr. Rupert can correct me, only one human-to-human transmission, which happened in Ethiopia. And considering that even in the United States there are 3-4 rabid patients or people with human rabies every year, it seems that the human-to-human transmission is not that frequent. But it's infectious, and if you take saliva, and in many cases we are able to isolate virus also from saliva from human rabies patients, so virus is there.
Dr. Franka, we have a question from Ricardo Lopez, and Ricardo's question is, could symptoms of rabies start for a few days and then stop for a week or so and then restart fully, and if so, why is it possible?
Yeah, thank you. So question is if symptoms could start for a few days, stop, and after restart after 1 week. It's unlikely, in majority of cases, since it is acute encephalitis, it progresses really towards, more severe symptoms. So it starts like a fever, confusion, but after a few days, taking into account that the virus is replicating and damaging neurons, there are no improvements in rabies, with the exception of few lucky survivors who were treated. But essentially, I don't believe there were any cases when symptoms stopped or improved and after got worse in a large extent. There may be, yes.
Question-related follow-up. How would you differentiate a patient as opposed to those that we may detect antibodies in without signs of illness, such as hunters, trappers, that has been reported in the literature?
Yes.
Does this mean these people became rabid and then we have an immune response?
No. Yeah. Thank you. So question is, there are publications or there are cases when people who either were never vaccinated but came into contact with probably low doses of virus have antibodies present in their serum or CSF. That's your question, right? So essentially, even though rabies is considered almost 100% fatal disease, obviously, at least based on experimental data from animal models and even from few human cases of survivors, it is essentially continuing. So obviously there are cases of so-called abortive or unapparent infections when animals or people may have been in contact with virus and they may have mounted some antibody response, but essentially the dose of the virus or variant wasn't pathogenic enough. When they didn't develop they may not develop clinical symptoms or signs, and they may have had some antibody response. If antibody are present only in a serum, it's difficult to distinguish if they have been vaccinated or not, because antibody are present in serum just after vaccination. Critical part is if antibodies are present in CSF, and those could be either binding antibodies or neutralizing. If there are antibodies present in CSF, it is likely that the patient or animal were exposed to virus or Lissa virus, and essentially these antibodies are a response of the immune system.
We have another question from Arturo Diaz. Arturo's question is, does pathogenesis differ for the different virus variants?
Thank you. If pathogenesis differ for different variants, pathogenesis or pathobiology is really dependent on multiple factors. It may be different for different variants, and it may be different for different species. So same virus could be highly pathogenic for one species, either animal or human, and less pathogenic for other species. So essentially there may be differences, but it's not possible, at least based on our current knowledge, distinguish between different variants based on clinical signs or symptoms. But obviously there are differences. They may be, they may not be. There may be difference in incubation period, in morbidity period, in pathogenicity. It just depends, besides variant, also on the dose and route of infection, and many other factors related to host or patient, some genetic factors, his immune system, and also age, etc. So there are many variables, and variant is one of them.